Welcome, everyone, to episode 174 of the 98 Crisis Jam. I'm your host today, or your moderator, rather. My name is Dr. Aisha Delaney-Brumsey. I am the Chief Strategic Growth Officer at Fountain Health in New York, a mental health clubhouse. And the topic today that Dr. Brian Mishara will be speaking about is helping frequent callers to helplines. It's going to be a great presentation. And excited to have you here with us, Doctor. Next slide. Just a reminder, as always, go to talk.crisisnow.com. You can see the upcoming presentations. You can register for the Crisis Jam. There's previous materials, all of that on this website. It's a fantastic resource. In addition to having some of the previous episodes. As I mentioned before we got started, Crisis Jam has actually getting close to 500 unique speakers since starting in 2020. And so if you have an idea for a topic, for a speaker, something that you haven't heard, something that you think is worth revisiting or worth diving into, there's a link in the chat right now for where you can put in your ideas. Those ideas can translate into tons of amazing speakers, as you can see here, and talks as well. This is an interesting article that came out recently in the New York Times, speaking about research that's asking the question, where researchers are exploring whether we're talking too much about mental health and the impact that might have on youth. On one hand, of course, they're weighing the impact of reducing stigma, raising awareness about mental health, having youth recognize their own distress as something that is manageable, treatable, and then on the other hand, is it priming youth with some normative distress to think of themselves as having a disorder? So they're asking the question about what is this more robust national discourse around mental health doing around youth's own reflection of their well-being. So definitely an interesting article to check out, and sure to have some controversy. There's an upcoming congressional briefing from the NCJA focused really on behavioral health and criminal justice. It's Tuesday, May 21st, has some great speakers. And so definitely check that out. You can get that link in the chat, as well as on the materials and website. And now for the crisis trivia hot seat. So good news, everyone. There isn't a crisis trivia person today. There isn't a person who's going to be in the hot seat. That means we are all in the hot seat. So get ready. Today, the question is, the number of frequent callers can vary and depend on factors such as the population served, availability of mental health services, public awareness campaigns, and societal factors influencing mental health. So this is about frequent callers to crisis line. So what do you think is the common reason why individuals frequently call to suicide helpline? Is it A, loneliness and social isolation, B, relationship problems, C, financial stress, or D, all of the above? And you should have a pop-up that has come up on the screen, and feel free to put in your answer. As soon as we have a few of those, we'll go ahead and we'll find out if we as an audience collectively won, and I believe in us. So wisdom of crowds is strong, and this is a particularly strong crowd. So a decent split, actually. Nice. About 30% of us thought loneliness and social isolation was a common reason why individuals call suicide helpline. And then a solid 2/3 of us thought all of the above. And so the answer is, drum roll please, all of the above. And so I was right. This is a strong crowd. The wisdom of crowd wins out. So in addition to mental health struggles and substance use, trauma, people often call the crisis line because they feel lonely, disconnected, as well as ongoing financial stress. So all of these contribute to frequent calls. And this is also going to be a great lead-in to our feature presentation. And so, without further ado, Dr. Mishara, can I bring you up? You're the director and center of the Center for Research and Innovation on Suicide, Ethical Studies, and End-of-Life Practices, and a professor of psychology. Thank you so much, and I'll pass the mic to you.
Thank you very much. See if I can, I don't have the control of the slide yet. It's not moving. So whoever is, it's okay, good. Well, it says you've ended slide control. It worked before. I cannot get this to advance. I'm sorry about this, but if you want, I can present without the slides, unless you have.
You could also, Dr. Mishara, you could just tell the person who who's managing the slides next, and they can advance for you.
Okay, wait a minute. There's here. No, there's control crisis jam slides. Okay, there we go. I can't control it myself, but I can control it from the screen. Great. Okay, so we're going to talk about frequent callers. I've been working with helplines for quite a while in a lot of different settings. I've helped start several of them, and we all know about frequent callers. Their definitions are very different. Some people like to refer to them as loyal callers or known callers. We all have them. Oops, I can't control it. Yeah, there we go. In Australia, for example, 3% of callers who call over 20 times a month constitute 60% of all calls. And in 988, and before it was 988 in 2020, 185 callers called 30 or more times in a month. 11,255 calls. There's a small percentage of Lifeline calls, callers, but quite a lot more percentage of the calls, 7% of the calls. I think the person who gets the prize called over 1,600 times in 1 month. I don't know if how that is actually physically possible. And we all have the concerns, one of which capacity issues. How can we answer all the calls? Many frequent callers are frustrating to deal with. Same person calling back, same stories. Sometimes we feel manipulated, bored. This is someone obviously needy of human contact. Wondering if they are actually suicidal, and often not in a current suicidal crisis. And the big question is, are we being helpful to them? We first, before we did a study where we had a contract to study the frequent callers in the U.S. Lifeline network, we reviewed what other people had wrote about this, and basically everyone says we need to do more research. Very often, the research mixed frequent callers with low-frequency repeat callers. So they define frequent callers anyone who called more than 2 times in a week, which is not all that frequent, particularly during a 4-week period where someone is in crisis. There are no research showing that frequent callers are different from other callers in terms of the percentage and types of mental health problems. They usually have chronic mental health problems. They also have a lot of physical problems, and they may use more mental health services, be more isolated or socially disadvantaged, more often anxious, or may have experienced more traumatic events. If you look through all the studies, there are some hints that some of these things may be the case. But every time people have looked at it, they are often at risk of suicide, as much or as frequently at risk of suicide as other callers. And they basically talk about mental health problems, feeling lonely, seeking advice, and talking about difficulties. Actually, in our study, we didn't find almost anyone who talked about, particularly about financial problems, and not so much often relational problems, though it did come up often in other studies of other populations. And there is no real outcome research showing how beneficial we are or how helpful we are specifically to frequent callers. So we had a contract to try to understand this and the nature of the calls, and frequent callers were defined and as people who call 30 or more times a month. We inherited this definition from NSPL, and we wanted to see how people react to them and how helpful it is. We did 3 complementary studies. In the first study, we identified everyone who called at least 30 times the preceding month. And in the next month, we got recordings of all their calls in the next month. And we identified 105 unique callers that we could identify. And the first study, we looked at the very first call of the month and the very last call of the month to see if they were any different and to see what's going on in those calls. And, I remember the very first call we got was from a woman who was just sort of whiny voice. She'd say, "Why can't I move?" And the helper, who would often recognize her, would say, "We didn't say you couldn't move. We just tried to help you move. I have cockroaches. This is a horrible house. I can't stand it here. Please, why can't I move? Why do you tell me I can't move?" Say, "Well, we're not telling you can't move, but we are trying to help you make some first steps, like looking for a new place." And then we go on. And then the next call we got was from the same person. And then the third one was from the same person. And we realized that this was one of the quite frequent callers. And we looked at the first and last calls. And basically, in a month's time, there weren't significant changes. Fewer callers were apprehensive at the end of the call. At the end of the month compared to the beginning of the month, but they were still calling for the same reasons. They still had the same emotional reaction. And we looked at all sorts of things. The amount of time they talked or versus listened also did not vary. Basically, when we examined how people reacted to frequent callers, we found that the counselors tended to focus on the situation, almost never on the feelings of the person. They were very good at exploring what's going on, what's happening, what are you doing, what's going on. 47%, we could not find during the entire call any expression of empathy. It was all concrete stuff about what's going on. 20%, one time they said something about feelings. 13%, 2 times. 10%, 3 times. Over 3 times there was a 10%. People were very respectful. They seemed to be generally kind to the callers, and it was all over the map of who was leading the call. Some people let the caller lead what was going on. Some were more directive. Wide variety. Again, counselors behave the same. First call of the month, last call of the month. We tried to see what behaviors were associated with improvements over time from the first call to the last call. Some people had improvements in various characteristics that we looked at, and we found a few things. We found that at the end of the month, people were more resourceful when counselors validated their feelings. Didn't happen often that counselors did that, but when they did, they seemed to be more resourceful at the end and asked callers specifically about resources. And also when they told callers what to do. This is different from suggesting what to do, but really were a little affirmative about that. People were more decisive, less confused at the end of the month. Also, when they were asked about resources, and there was discussion of their coping strategies, and solutions were suggested to people. And one of the indications we looked at was how the calls ended, and the callers were more likely to thank the counselor at the end of the call when there was some moral support provided during the call, and when near the end of the call, the counselor asked the caller to call us back if you need to. The second study, we added a possibility of answering some questions at the end of the call. So people got a recorded message saying that please stick around and answer a few questions to help us understand how to better help you. We got 113 responses from frequent callers. 36 of them were not unique responses. They were from 17 different callers. And when we asked, as a result of the call, I feel better, more calm, more relaxed, more than a third, 36%, disagreed and said no. 39% somewhat agreed, and 25% completely agreed. So some people felt better. When we asked, as a result of the call, I feel I have more control over my suicidal thoughts. I must mention, I didn't mention it before, that they talked about suicide and often had history of suicide attempts, treatment for suicidal ideation. 47%, almost half of them said, no, didn't help me with my suicidal thoughts. 31% said, somewhat agreed. And 1 out of 5 said, yes. So you're helping a little over 1 out of 5. It depends on if you want to see the glass half full or half empty. 42% didn't feel it after the end of the month they were better able to cope, but 36, but that means that 58% did. 36% said they were not heard, understood, or respected. And counselors provided moral support and talked about their own experience. This was associated with the caller feeling better at the end of the call. Talking about your own experiences, we found, was associated with improvements in general. And this is not when the counselor says, well, you think you feel bad, you have problems, let me tell you about mine. It was more sharing some shared experiences, saying, I sometimes feel lonely too. I understand how you're feeling. I went through a tough divorce. In our third study, we looked in depth at up to 20 of the calls. We took a random selection of 24 callers who called us 318 times, and all the calls and these were all calls over 3 minutes long. And if they called less than 20 times, we listened to every single call. And if they called more than 20 times, we randomly selected 20 calls, and we kept selecting people until we hit what we call data saturation. That is adding more people. We didn't get any more information. And we did narrative summaries of all those calls, and then we analyzed the content of all the 20 or calls, or fewer if they called less than 20 times that month. Basically, they had a lot of problems. They had social problems, health problems, mental health problems, 4 out of 5. Very often, the conversations were difficult, tangential, incoherent. Sometimes people continuously talk. Sometimes they got irritated, aggressive. They weren't pleasant calls often, but not always. Even though many of the calls seemed very difficult, 79% of the callers had some calls that they seemed to really get a lot of. And almost half those, 46%, were when the counselor expressed and seemed sincerely interested in the caller's problems and seemed really happy to talk about them, enthusiastic of discussing and talking with the person, which was often not the case. And almost 2/3, 63%, you pick any one of the calls, they're all pretty much the same. There was no change over time. 3 of the 24 callers, they had incredibly positive improvements over the course of the month. So, for example, that woman who was calling, why can't I move? One of the first calls we got was a call from her, can't get anyone to help me move next week. And she found an apartment, she was moving, and she had made a lot of progress. And by the end of the month, she had moved into a nice place and was very happy about it. Still whiny and complaining about things, but seemed a lot better off. We found there are fewer frequent callers than the helpline thought they had, because some people they were identified as calls coming from the same phone number. And some of the calls coming from a single phone number we listened to, they were all from different people, because if you use Skype, they route it through certain specific phone numbers all the time. So it's not the same person. It's just they're using Skype or using a calling card. Almost half, again, 45% of people who were frequent callers last month were not calling as frequently the next month. They were called less than the 30 times and wouldn't qualify as being frequent callers. But sometimes this was because their calls were limited. They said, I'm sorry, you can't call anymore. You've called your, 1 call a day or whatever it is, or so many calls a week. They have serious chronic problems. They also have acute crises, and they're often very precarious living situation. And again, the counselors focus on the immediate situation and are rarely empathetic or focus on emotions. But whenever they are, it really seemed to be of some help. And they focus on, what are you doing today? They rarely try to deal with the big problems going on in someone's life. They focus on the problem. Hardly ever talk about the person. Who are you? What are your aspirations? What are your thoughts and feelings? The callers really rely on the lifeline as a way of coping. And basically, they do a lot of the same sorts of things you would do in a crisis situation, dealing with minor problems and not so much focusing on the big picture. So, recommendations. Recruit people, identify helpers who are warmer and empathetic. That's related to more positive outcomes. Develop care plans, not necessarily management plans. Don't push solutions if callers push back. Half the callers reject all the solutions suggested, and it gets very testy when helpers insist that they should do what they think they should do. Doesn't lead anywhere. Often risk assessments are ignored with frequent callers. You should develop a protocol and training of what do you do when someone's incoherent or has trouble communicating. The counselors just seemed lost about this. Similarly, when someone was obviously having psychotic symptoms like hearing voices, they had no idea what to do with it very often. And also, there were a lot of people with physical pain and handicaps, and the counselors tended to focus on how to cure the problem, which is probably uncurable in most instances, but don't know how to talk with someone about their pain and show some empathy about the pain. It seems that it's helpful if callers can maintain relationships with their favorite helpers, if this is feasible. Some counselors seem really bored, uninterested, and upset during the calls, and callers don't respond very well to this. We can understand why, having listened to all these calls. And the main thing probably is if you're going to be helping frequent callers, you must teach counselors to realize that if you're going to help people, it's going to take months. And don't expect that it's going to be like a crisis situation where people feel better at the end of your call. They'll feel better at the end of 20 calls, 30 calls, 40 calls. If you're going to be of help to them, you're not going to help everyone, but you'll help a significant amount of people, but it's going to take time, and you have to decide if this is what you want to be doing. Focus more on the person, their strengths and capacities. They are suicidal. If you try to refer them to other services, usually the other services reject them. So the question is, are you willing to deal with frequent callers under the circumstances where you're in it for the long haul? You have to change your perspective on those calls. Some will be helped, some will not. How many people do you need to help to justify an investment in time and energy into a lot of people who may not profit from it, though a significant number, well, it depends on what you call significant, will be helped. Thank you.
Thank you so much. You're getting a lot of positive feedback in the chat, but thanks for that really in-depth review of your research around helping frequent callers. And there's some questions in the chat, which if there's time after the discussion, I'll pull those up. And so we'll go ahead and get started with our discussion on our crisis roundtable. Can I bring up Dr. John Draper to get started?
Thanks, Aisha. Brian, it's good to see you, and thanks for the presentation. Really appreciate the findings. In fact, we appreciated it at the time when you provided it to us. We commissioned the study at Vibrant for Brian to do on familiar callers because it wasn't just because we had so many familiar calls that we were concerned about that impeding the connection or access of people who might have more immediate concerns. And that's often cited as an issue. But for us, what we were really aware of is that there are very special interests and needs of individuals who are calling many times that perhaps our service isn't designed for, yet a service needs to be designed for. And if we could learn more about what the interpersonal characteristics were and the presenting problems of the individuals who were characterized as frequent callers, perhaps we could design a specific service for them, perhaps a subnetwork of sorts. After we looked at Brian's findings, one of the things that really occurred to me is that maybe a good place to start would be really enabling a subnetwork of peer support helplines. And I'll talk more about that in a little bit, but I think it's also interesting to just get a sense, and Brian gave us a little sense as to what degree or not our current system takes care of familiar callers. And what was interesting is there was a study of NYC Well, which is also operated by Vibrant. It's a 988 center. And they did a satisfaction survey, but actually they looked at whether or not the NYC Well program was helpful for callers. And this is about 1,000 callers that they surveyed 2 weeks after contact and then 6 months after contact. You usually don't look at a 6-month longitudinal study on the impact of crisis helplines. And what they found, interestingly, about 90% of the people said, yeah, it did help them at least a little or a lot with their problems. But it was mostly true for people who contacted the helpline multiple times over a 4-month period. In fact, people who contacted NYC Well only once didn't really report a lot of reductions in distress. And the ones who did contact it, anywhere from 2 times to more than 20 times, even up to 100 times, reported the highest benefit after 6 months, from about a 12 to 21 point lower reduction in distress levels. So this could be due to a few reasons. It could be that you're more likely to call again if you had a good experience the first time. So if you didn't have a good experience, you're not going to call back. Or maybe they just didn't have as much distress, because if you have higher levels of psychological distress and your needs are more complex, as Brian was talking about, than callers with lower distress, one call ain't going to do it. You're going to, and really our centers are not designed for those more complex needs. So perhaps a helpline service for multiple contacts for people with more complex needs, which peer support services are better designed for, could be established and integrated into 988 caller options, so we can better help the people with the kinds of issues that Brian describes. It's interesting, the NYC Well does have a peer support program, and when we surveyed about 170 helplines 3 years ago, when I was with Vibrant, about 70% of them said that they had relationships with or they operated local peer support services. So perhaps we could leverage those capabilities our centers already have and look to build some kind of peer support network. And some say, well, we don't have best practices for them. Well, we do have best practices for peer support services, but not peer support helplines. So maybe what we should do, just as we did back in 2001, when we established a national network of crisis helplines without really any definitive research that showed that they worked, maybe we should do something similar for a subnetwork of peer support helplines with the same kind of dedication and rigor, evaluate them to determine what those best practices are. So those are some thoughts that have always occurred to me since being acquainted with Brian's terrific findings.
Thank you so much, John. And actually, your reflections really responded to some of the comments in the chat about, what are the resources that you could connect people who are frequent callers to, including like peer support services, warm lines. It reminds me a lot too of work I did when I was in the New York City Mayor's office, where we looked at frequent callers to 911 and the level of complexity of those needs. They also, similar to frequent callers to crisis lines, had really complex needs. And one of the solutions we were pushing forward was really being able to send peers to folks,
right?
Recognizing that the crisis response is not sufficient for a long-standing challenge. So thank you so much for that, John. Really appreciate the reflections. Next up, I'd like to bring forward Greg Border, Chief Clinical Officer at Lines for Life.
Thanks, Aisha. So hi, everybody. My name is Greg, and I run I'm the Chief Clinical Officer at Lines for Life, which is located in Portland, Oregon, and we answer the majority of 988 for Oregon. So in the 11 years that I've worked at Lines for Life, this has probably been the thing that we have struggled with the most and spent the most resources trying to solve. And I feel like we're still continuing to change and adapt, and we have not exactly landed where we want to be. We've tried every kind of approach that I could think of, from having subgroups of teams that only answer we call them callers with complex needs, but we've also in the past called them familiar voices. We've called them frequent callers. We've kind of had, there's all kinds of ways of identifying these folks. So we've tried care plans. We've tried, I mean, you name it, we've tried it before. When I think about our center, there are really two things that I think are big challenges. So one is the obvious operations concern, which is around how do we balance answering the KPI, so the key performance indicators for all of our calls, and still serve our callers with complex needs well. Some of our lines, 60% of our calls, 70% of calls on some of the lines are callers with complex needs. Some of them are as low as 30%, but I would say on average, if you look across all of our lines, probably 40 to 50% of our time is spent on handling calls from callers with complex needs. As noted in the chat, they can tend to be longer calls, so it's really a balance. So the operation concerns is something that I think we're always trying to figure out how best to handle. But really, when I think about frequent callers with complex needs, I think one of the sort of philosophies that we have at Lines for Life is that we feel pretty strongly, just based on our experience and all the different attempts that we've had over the years, that for many callers, we don't want our crisis lines to replace community services that actually we think oftentimes better serve individuals. Now, of course, there are some individuals who don't have access to community services or natural supports because of location or cost or all kinds of things. But for many folks, we do feel that creating a dependency on the crisis line is what sometimes happens, because it's easy, it's available, it's easy to reach, I should say. It's available 24/7, whereas a case manager or a therapist may be available only once a week or even less. And so we're really trying to figure out, rather than creating a situation where a caller feels that the crisis line is the only place to contact because of the ease of accessibility, we're trying to figure out with those individuals individually, like, what are the resources that are available to you, whether it be natural support such as family or therapy or case management. Because we believe that the ongoing continuity of care is really most times what is needed. So when you call our center, you're not gonna, like, say you have a great experience with Debbie, you're a caller with complex needs and you reach Debbie and you've had an amazing experience. The chances of you reaching Debbie again are not very good, because that's just not how our crisis center is set up. And so I really believe, and we believe, that the ongoing continuity of care is so important with folks, to not repeat their story each time and to really be able to work on a care plan that goes deeper than what we can do on a crisis line. And so that's the other thing that we're really trying to juggle, is, clinically, what do we think is the best option for getting the person help that they need.
That's great, Greg. Thank you so much for surfacing both the operational challenges that familiar callers place, or that the operational challenges supporting people who are familiar callers, as well as some of the challenges of really figuring out what is the best way to match people with an intervention that will support them in the long run. So really appreciate that. And that does, as you noted, speak to a lot of what's also going on in the chat. I have our final discussion. Jay Lewis is the AVP of Clinical Standards Training and Practices Division with Vibrant Emotional Health. Welcome.
Thank you so much for having me. It was very exciting to hear Greg talk. So, because Greg illustrated a number of points that we try to make at the administrative level for all of the 98 centers in terms of how they interact with familiar users, or familiar individuals, as that's the phrase that we use. We recognize that centers throughout the network may have some different names, but we are encouraging folks to call or to use the term familiar individuals. So as a way to recognize recognize those folks who reach out for assistance frequently. We use individuals just because we are receiving calls, chats, text, video phone users now who are, you know, all different modalities of 988 service that we're providing. We certainly have a high percentage of regular contacts, and a large percentage of our calls are from folks who meet the criteria that Brian talked about that we had given him, was that 30 calls in a month, to sort of give ourselves some criteria to establish who we consider a familiar caller or a familiar individual. We have listened to that research that Brian did in 2020. So there was a number of elements that we could take from that into actionable items. And I wanted to spend some of my time talking about those actionable items today so that folks knew kind of where we've come since 2020. So with resources that are available for 988 centers and 988 crisis counselors to look at some of those things that Brian had noted in the survey. So we have put together, and actually prior to 2020, but we've continued to put together and advance a number of guidance documents, sample policies for working with familiar callers, and other supports around how to build care plans, like Greg was talking about, so that centers who aren't as familiar, or who need a little bit of guidance in how to put those things together, we have a number of samples available on our network resource center. But largely, you know, other information that we have is we use this time to put together a brand new online training course. So that is available for all 988 crisis centers in the network, really specifically looking at some of the factors so that we wanted to make our 988 centers aware of, particularly one that we want familiar callers. Like we want to help familiar callers. We recognize the complex needs that they have. We recognize that familiar callers are oftentimes more at risk for suicide. And yet we know that they're often asked less about their thoughts of suicide. They're often asked less about, you know, the issues that Brian was pointing out in terms of offering empathy and things like that. So we wanted to think about how we could address some of those things. And so we put together an entire new online training course that's been available since November of last year for all crisis centers in the network. So far, over almost 3,000 people have taken that course. And I was just looking at some feedback that we've compiled from takers of that course, and it seems to be really helping folks. We are going to be looking at how we can measure the impact that that's had. So at some point in the future, but right now, the self-report from crisis counselors and the increased focus on listening skills. So how to make connections, how to assess for suicide within the context of a familiar contact relationship. All of those things seem to have been well received by crisis counselors, and they feel like it's improved their communication with familiar users if they've taken the course. So there's a lot of great stuff in there, and I wanted folks to know that that exists. A lot of the things that we also put in the third module of that course are about helping crisis counselors to manage their own reactions. You know, sometimes there are ways that crisis counselors communicate with each other about some of their frustrations with dealing with folks who regularly or more frequently contact for help or for support when they feel frustrated, when they don't know how to offer that support. Some of those situations that Brian talked about where maybe there's longer term problems that we don't have easy solutions for through a crisis hotline, and the crisis continuum has not yet evolved to be able to support those folks, or the social services system hasn't yet evolved to be able to support those folks in the way that we need. So we look at how we're managing our own emotions and reactions to working with familiar callers, hopefully to set us in a better place and to set every crisis counselor who accesses that material into a better place to engage and to know some of the things that actually can work and can help to engage, to keep that person safe, to keep that person feeling supported, but also, like Greg is talking about, to connect to the larger continuum when there are those services available. So thinking about.
Shay, I'm so sorry to interrupt, but we're just running a little short on time. Can I ask you for your final thought?
Yep. So final thoughts just are that, you know, familiar callers are an important, and familiar users are an important part of our service. We recognize that they're more at risk. We want to do better to help them. And we've tried to take a lot of actions based on some of the research that we've learned about to support our 988 centers to better support those users.
Thank you so much. It was great to hear about the what you're doing at Vibrant and how you're supporting other 988 the 988 centers across the country. And for all the presenters and discussants, there's a bunch of conversation going on in the chat. So if you have time, please do jump in and respond and send any resources. I know that people are really engaged. Next up, we have, let's see, we have Dr. Belina Shaw from SAMHSA for the SAMHSA update.
Thank you, and thank you for that awesome presentation. Just familiar faces, and they are they go by so many names that they show up in so many different settings, and it's important to make sure that we're understanding how to best serve their individualized and unique needs. Sorry, my allergies have decided to attack me today, so I apologize for sounding like a cross between a frog and a, I don't know, squeakiness, but nonetheless, we will proceed. So this month, of course, is Mental Health Awareness Month, and I'm very excited that we have several events going on at SAMHSA, and especially in the Center for Mental Health Services around Mental Health Awareness Month. Obviously, we also celebrated Children's Mental Health Awareness Week last week as well, and so we have so many events going on, that some of which are virtual and you can still attend, and I just want to make sure that you're aware. So if you go to the link that Georgia just posted, you'll find a calendar of events. Some notable ones are specific to youth. I just presented with Jill Mays from the 988 office just a couple of minutes ago on crisis care in youth at the All Systems Go conference that is focused on not only the Children's Mental Health Initiative or Systems of Care grantees, but other individuals who really want to use that systems of care approach and are interested in systems of care for youth. So that is, there's another day of that, and you can get engaged in that. Also on Friday, there will be a Children's Mental Health Symposium that will be focused on children's mental health supports widely and broadly. And just some other things that are happening in person is that we had the National Child Traumatic Stress Network Conference that is currently ongoing. We also have the Advancing Wellness and the AWARE grantees, sorry, it's the government acronyms, the school-based grantees that we have. They will be having a conference next week, and we'll be also focusing on some equity issues and presenting on Black youth suicide prevention there. And then when we think about children, we should also think about families. And so I also just wanted to point us to the exciting launch earlier as well of the Maternal Mental Health Task Force's report and an action plan. So that is also available as well. And yes, there's a lot of stuff going on in this month. We're very excited and hope to see you virtually on Friday for that meeting.
Thank you so much. It's really exciting to hear everything that SAMHSA is doing around Mental Health Awareness Month. Those are fantastic topics and resources. Next up, we have the Nashville update with Dr. Brian Hepburn. Brian, take it away.
Thank you, Aisha. And then building on what Belina said, I just wanted to reinforce regarding the national strategy to improve maternal mental health care that came out this week. We think this is a very important document. We know that maternal mental health conditions, substance use disorders, and their co-occurrence have reached crisis levels in the United States. Suicide, drug overdose, other incidents and conditions related to mental health and substance use disorders are the leading cause of pregnancy-related deaths. So the vision set forth by the national strategy is one in which maternal mental health and substance use care is seamless and integrated across medical community and social systems. There are 5 pillars that are identified. 1, build a national infrastructure that prioritizes perinatal mental health and well-being. 2, make care and services accessible, affordable, and equitable. 3, use data and research to improve outcomes and accountability. 4, promote prevention and engage, educate, and partner with communities. And 5, lift up lived experiences. I put the link in the chat. This work is very important, and we really thank SAMHSA for their leadership in this and developing this national strategy and also the others that were identified by Belina. So thank you.
Thank you so much, Brian. Always fantastic information. So next up, I have Dr. David Atkins with the Tech Corner. Dave, please take us away with your 4 minutes on a topic that I'm sure none of us are worried or confused about at all. So
Yeah,
please.
it's great to be back here. Thank you so much, Aisha. Yeah, well, this is the first in what will be 4 kind of brief spotlights on different issues related to AI. Ideally helping to inform you to be a better consumer of AI in crisis care. And so today, I'm going to just touch briefly, really more on what AI is not. Next slide, please. The media loves to portray AI as kind of all-knowing, omniscient, often with a somewhat negative spin. Some of you might think of the Terminator movies, but it's not only in the movies. Next, please. There also is this conversation among talking heads in our community, and so it creates this dialogue within our culture about what AI is and presents it as both kind of omniscient, very human-like, and often with a kind of negative spin. And if I could talk to Elon about this and other things, I would say, stop it. Okay, just this is silly. All right. Next slide, please. So within the AI development community, there is this idea of a broad, very human-like AI, and the term is called general AI. And you can see in here that this is really the kind of version of AI that is very human-like, capable of learning and reasoning and performing a variety of tasks. Next, please. The key point here that on this slide is that this is all theoretical. This is not AI that is in use. Next, please. What is actually in use from AI is AI that is developed for very specific tasks. So it is developed for specific tasks, trained on specific data, and evaluated for the success around those tasks. And so we can see a couple examples here on the slide, such as speech recognition, image recognition. And image recognition is a good example where this is something that humans are fairly good at. Is there a dog in this picture? Is there a car in this picture? And AI can be trained to function like a human, but in this very narrow domain. Somewhat similar in some of our own work related to crisis, we have been training AI models to detect suicide risk assessment, inquiring about suicidal ideation, about plans, about means. Again, tasks that humans can do, but the AI can then scale these up. But the key point here is that just because the AI can do this specific task does not automatically mean it can do others. And so that's really a critical point for us as we think about AI and its applications to crisis care, is that we want to make sure that these are specific tools developed for specific tasks. And I think just at a more human level, realizing that AI is not an omniscient robot-like system that is potentially listening to calls or training me, I think might be helpful. Next slide, please. So real quick intro on what AI is and is not today. And then we'll be talking about how do we think about quality in AI systems, what makes for a robust, validated AI system. We'll talk a little bit about generative AI. If you happen to have been at Brad Pendergraft's talk at AAS, he was focusing on generative AI, and it might seem fairly human-like. So we'll touch on that. And then finally, we'll wrap up in August with different use cases for AI in crisis care. Thanks so much.
Thank you so much, Dave. I appreciate you breaking down this topic, particularly over a series of short discussions. Finally, I'm going to bring Stephanie Hepburn for crisis and Gabrielle Solis Torres for the crisis talk section. Stephanie, I'll let you take it away.
Thank you. Gabriela, if you could talk a little bit about what the impetus was for developing the essential metrics for alternative emergency response programs.
Yes, of course. Thank you. So I work for an organization called the Government Performance Lab, or the GPL for short, but we're an applied research and technical assistance organization that's based out of the Harvard Kennedy School. And the GPL has supported now 32 governments, I believe, setting up unarmed alternative 911 emergency response teams or community response teams, or oftentimes also called like crisis response teams, for about 4 years now. And through that work, we realized that although all our government collaborators were on board with collecting and using data, often they didn't really know what to collect or what questions they should be asking of the data or what they should be prioritizing for review. So this tool is our attempt to help folks answer those questions through a culmination of sort of all of our learnings the past couple of years into an actionable essential metrics tool.
And you also dug into not only the local governments that you helped, but you also looked into the data, if I'm correct, for 17 other local governments. Is that right?
That's correct, yes.
So if you could talk a little bit about the metrics tool, what that looks like, and the different ways that local governments can utilize the tool as well.
Yeah, of course. So this tool includes 29 common actionable metrics used by alternative emergency response teams across the country. And like Stephanie said, we identified those both through our governments that the GPL supports, and then a scan of publicly available program data of other programs across the country. And then each metric that we list in the tool is paired with a source for the data, a recommended frequency of review, and a priority of whether that metric is essential or supplemental for governments to collect. And in this, we were really hoping that the tool will help program leaders feel more equipped to use their data to do 3 things. So the first is reactive troubleshooting so that they can make immediate course corrections in their program. The second is tracking impact and managing performance to understand how well programs are doing at serving their target populations. And then lastly, we're really hoping that it helps program leaders make a case for expanding or iterating on their alternative response programs.
And then you said also local governments can look at it through core questions. So can you explain that a little bit?
Yes, correct. So there are sections in the tool that are broken up by important questions that leaders should be asking themselves, such as, are we supporting the people that we set out to support? Are we diverting calls in the way that we anticipated? So every one of the tools is bucketed into some very clear core questions.
Thank you so much. What I love too is that provides a feedback loop so that, and you give recommendations. So for example, how often partnerships should get together to review the data. And you said something at the very end, if you don't mind, why partnership is so important and why collecting this data and the feedback loop helps.
Yeah, so one thing that we've learned in working with our government is that these alternative emergency response programs are extremely interdepartmental, and all of this collaboration and coordination across both your 911 call centers, the responder teams, your behavioral health department. So all of the key stakeholders is extremely important. And the other piece is that the data needed to really understand how your program is doing lives in different data systems. So that coordination across those departments is extremely important.
Thank you so much for hopping on with me. I'll pass it back to you, Aisha.
Thank you, Gabrielle. Thank you, Stephanie. So thank you all for being here for this 174th episode of the Crisis Jam. Next week, come back for the 175th on tobacco use, mental health, and substance use, thinking across both across systems, across conditions. And in 2 weeks, formative research for 988 messaging. It's been a pleasure to be with you all today. Thank you again to the presenters and to our discussants and to the audience. And have a great rest of your Wednesday.